Good evening, everyone. Welcome to this evening's webinar, Exploring Lung Cancer Targeted Therapies and Immunotherapy with Matilda Hamilton. It is really special to have you back, Matilda. For those who don't know, Matilda was my predecessor running the Rural Health CME, and then she decided to go and embark on her general physician training in Rotorua and has been doing some oncology and contacted me excitingly to say that she'd like to discuss this topic. And I think it's a great topic to cover, and it's got some really good focus for rural New Zealand, especially looking at some Māori health statistics. So as always, our session is run by the section of Rural Health, the Department of General Practice at the University of Otago, and is supported by the Rural Hospital Medicine Division of the Royal New Zealand College of General Practitioners, and is endorsed for 1 hour of CME. At the end of the session, if you can complete the evaluation form and document your medical council number, and then I can upload this CME for you. All of our sessions are recorded and can be found on our Learning on the Leaning on the Fence post YouTube website, and I can also put that into the chat at the end of the session. So I'd also like to thank Gary Nixon for coming along and being our support man this evening, and so we look forward to any input, any questions, just put them into the chat. We want this to be really interactive. Matilda's keen for questions, so it looks like we're going to have an elite wee group today, so I think this will be fun. So I will hand over to you, Matilda, and we will start.
Can you hear me okay, Lucinda?
I sure can. Perfect.
So kia ora koutou, everybody. Thank you very much for having me back, Lucinda and Gary. And yeah, I'm really keen to take questions and just clarify things as we go along. So definitely just put things in the chat, and Lucinda will interrupt me as we go along. I did this presentation quite formally to begin with at our grand round at Rotorua Hospital, and then I've done it in kind of a few informal settings. So it's definitely perfect for interruptions and questions as we go along. So I'll start with a story, and then I'll get into the thick of it. So I'm, for clarity, I'm a general medicine trainee, but I'm doing oncology at the moment for the second time round. So I will begin with a story, a sad story, but I promise things will get brighter from here. I was working one evening in Rotorua, the admitting medical registrar. I was asked to see Ripeka, a mother of 12 from Turangi, recently diagnosed with lung cancer. Not even having had the opportunity to be seen by an oncologist yet, she presented with back pain on many occasions, and then eventually being diagnosed with multiple metastases. She was sore and tired and thin and facing her death. Her children were afraid. She had 12 of them. They were afraid of what lay ahead, afraid of their mother's suffering, and afraid of taking their mother home without addressing her symptoms. But Ripeka didn't, and she did not want to stay. Her daughter told me adamantly they would not take her home without her symptoms being better sorted. It was late, Friday evening, and this whānau had 2.5 hours to travel home. I held Ripeka's hand and asked her what she was most afraid of. She looked at me in the eye and she said quietly, dying in hospital. Ripeka was not actively dying, and as I looked at her, I said that yes, she was going to die soon, but most likely not tonight. And perhaps I said it with more certainty, not tonight. Well, I was wrong, as we often are with these things. Ripeka died suddenly that night, some of her daughters sleeping in the room with her. I, of course, felt terrible and guilty. I chose this story not because this is the only patient I've seen die of lung cancer, or to share how ridiculous it is to promise a patient such a thing, but to capture a glimpse of the tragedy that surrounds lung cancer, a tragedy that is lived out time and time again in this hospital in Rotorua and in Taupo in our community from Turangi, and why it is so crucial there is a glimmer of hope for patients, whānau, and clinicians. That's my story. So the things I'm just going to cover as we go through is the sense of a bit of hope in this area that has been previously pretty dismal. I'm going to touch upon the subtypes of lung cancer because this has a really big bearing on what treatments are available these days. And also the staging, because I think these things can start to feel quite distant from, way back in medical school. But again, it makes a big difference to what treatment options are available. a little on the epidemiology, and this is particularly relevant in New Zealand because this disease has such a high prevalence in our Māori population, and then onto the treatments that are currently available. In particular, the targeted molecular treatments, then on to immunotherapy, with a bit of an emphasis on the toxicities associated with these, because this is relevant to all practitioners, and particularly those working in the rural setting who may not be coming across them all the time. And I'll flick through a few case studies as we go along and just touch upon what is available in New Zealand. So what I'm not going to go to in heaps of detail is screening and smoking, particularly not really smoking, because I think we're all too aware of that. With regard to screening, there is growing international evidence that screening of high-risk patients for lung cancer, and that's using low-dose CT scans, can actually reduce the mortality associated with lung cancer. So this is the idea of catching lung cancers kind of stage 2, stage 3, so that the stages that it's actually curative and treating it there. Because as we'll see as we go through, it's all too often diagnosed at stage 4 in incurable stage. And this is particularly relevant to rural practice because that's where pockets of high-risk populations exist. And they're actually in Northern Australia rolling out some pilot studies of screening in more isolated communities. So they've actually built these big buses that have CT scanners in them, and they're going to be going around communities, Aboriginal communities in the north. And this is logistically just so complicated because then you have to engage with these communities to get the screening done and then all the treatment that goes with it. That has been proposed in our community with one of our respiratory physicians who now does palliative care. Unfortunately, the funding got turned down, but the idea was that they were going to actually roll up the screening with just lung health in general. So it's a real shame that that kind of hasn't come to fruition yet. So I'll just start with one case study, and this is just to kind of offset the sadness of so many of the patients I've seen, like I described in that story. So this is one of the patients I saw as an oncology reg. She's a 72-year-old woman. She presented in 2021. She had the typical breathlessness and cough. She'd been really well otherwise, other than being an ex-smoker. She had a really busy lifestyle. She was fit and active. She went on to have a CT scan that showed a mass in her right upper lobe, and she already had established metastatic disease. So that's classified as stage 4. And she had adenocarcinoma, which I'll go into in a bit more detail in a moment, but that's the most common type of lung cancer. So this is her initial chest x-ray. It's a pretty typical appearance there in the right upper zone. So she was in a position, she had funded chemotherapy, that's what's available in the public system. And when she was diagnosed, Keytruda, so we'll go into lots of detail about Keytruda, pembrolizumab, I'll call it from now on, was not actually funded. So, but she was in a position to self-fund, which the vast majority of my patients certainly aren't. So she had a really good response, reduction in tumour size, and she's basically had no progression of her disease 2 years down the track. And since then, pembrolizumab's actually become funded, so her treatment's fully funded. When I last saw her in clinic, she was travelling. She was about to go on a motorbiking tour around Romania, and her ambition was to die from a motorcycle accident rather than her lung cancer. So this is, an example of like really excellent response to treatment in a disease that pre-Keytruda she, definitely would have died from by now. Oh, sorry, that's just demonstration of the significant change in her CT scans, really appreciable there. So I just wanted to touch on sort of why I'd chosen it initially for my grand round topic. And I think that, from a point of view of New Zealand, lung cancer has such a significant impact on us. Like they've got the highest cancer-associated mortality worldwide, but we have a really high incidence in New Zealand, particularly because it's so common among Māori men. And then that combined with the fact that up until recently, we really haven't had effective treatments available, it's had a really huge impact. And I guess that's really struck me since I've worked in Taupo and Rotorua, the significant impact. But then that's coupled with, recent progress in treatment. So we're, definitely seeing some progress in that area, coupled with gradually smoking rates coming down, but we're still not going to see the real impact of that for a couple of decades. So I said to Lucinda, I'll just skip over this, but I don't want to delve into it too much. But she said, spend a bit of time, because sometimes we don't think about these things if we're not
too much time. But these are all quite historical, aren't they? These concepts, they're quite historical for some of us, aren't they? We don't look at this breakdown anymore. Well, I don't.
So lung cancer can be divided into two major groups that are really quite different from each other. And that's small cell lung cancer and non-small cell lung cancer. The therapies that I'm going to be talking about tonight apply to non-small cell lung cancer. But I do want to spend a little bit of time talking about small cell lung cancer because it has some unique characteristics that are really important clinically. And then just going back to the non-small cell, it's broken down into adenocarcinoma, squamous, and large cell. And the majority of our patients either have adeno or squamous. So just looking at what proportions we see, as I mentioned, adeno by far and away the most common, but small cell does make up a reasonable proportion. So the thing to be aware of in small cell is that it's really, really common amongst smokers, and it's really, really sensitive to chemotherapy. And for that reason, it needs to be started urgently. So applying this to the rural context, this is one of the reasons that a patient who presents with a new malignancy that you suspect to be a metastatic lung cancer needs to be worked up really promptly, and to try and facilitate that obtaining a biopsy as soon as possible, because small cell lung cancer can be really rampant and people can die. If left untreated, people can sort of die within weeks to months. And if they get the opportunity to have chemotherapy, they can feel a hell of a lot better, so it's so sensitive, and secondly, they can actually get a significant length of time added to their life. And it's also really common for these patients to have brain metastases. So for anyone who has access to CT in their setting that they work, it's a good thing to get a CT scan early on in the workup of these patients. And that's kind of holds true for most patients with metastatic lung cancer. They should have a CT relatively early on. So
is that specifically, Matilda, of the brain, of the chest, a pan scan, when you say a CT?
Sorry, so they need a staging CT. By staging, we mean chest, abdo-pelvis, to see how extensive their disease is and what organs are being impacted upon. And then a brain included, because it's so common for patients, particularly the small cell, to have brain metastases, and it's going to make such a difference to the way that they're managed and kind of anticipatory management. Do they need dexamethasone? Are they going to need to be transferred to have radiotherapy at some stage? But yeah, and I think just that the main thrust is like the importance of the biopsy, and you're really advocating for your patient, because I know it's not always straightforward getting biopsies. I mean, in our region, in our area, we have one interventional radiologist who covers our Turangi, Taupo and Rotorua patients, and he's just fallen off his mountain bike, and our whole kind of biopsy services just come to a standstill. I mean, a lot of them can be done by the respiratory physicians with bronchoscopy, but otherwise, reliant on this one person. So when it comes to small cell, you might see in letters, the way it's described, it's either limited or extensive, as opposed to non-small cell. I'll touch on how that's staged in the next slide. And unfortunately, like the vast majority of our patients in New Zealand are diagnosed with extensive small cell. So they have widespread metastatic disease when they present.
And it's limited by definition just to the chest.
Yeah, so limited is like usually, ideally, a single lesion, but usually they have nodal involvement as well, but just localized to a particular anatomical area.
Great, thank you.
So the staging of lung cancer non-small cell is really, really complicated, and it's done in the MDM and things, and I wouldn't want you to spend any time thinking about it in this format. I think it's probably even I might just move on to the visual depiction that I find this the easiest to understand. So stage 1, 2, and 3 can potentially be curative. And in that case, stage 1, it's just a localized lesion. Stage 2, there's very close by nodal involvement. And then stage 3, you do have nodal involvement more extensively, but only in that one side of the chest. And then stage 4 is disease, extrathoracic disease, a tumor to the other lung, or those patients who we see who already have a pleural effusion at diagnosis. So because the important thing here is that the vast majority of lung cancer patients are diagnosed at stage 4. So this is just looking a little bit at the statistics in New Zealand. So around, over 1,700 people a year die from lung cancer. And this is a graph looking at the incident rates and across various different malignancies. And I guess what I just want to just illustrate with this picture is that the darker green line is Māori and the lighter is non-Māori. And, this is very much a disease that impacts on our Māori population when you see the contrast between the two bars there.
That's an incidence rate, isn't it? That's not the mortality rate.
So this is the incidence rate.
Yeah.
Of diagnosis. Yeah. So vastly more people receive the diagnosis. If we look locally at our Rotorua numbers, this is actually the Lakes DHB, so catchment of Taupo as well. In a typical year, there'll kind of be 70 plus patients diagnosed with lung cancer, and usually over half of them are Māori, and there's around 61 deaths. And unfortunately, like a really high proportion of our patients are diagnosed in ED, which is probably common across the country and would be common only occur in rural hospitals. And I say sort of sadly because it's usually that people are really symptomatic and at a late stage. And also it's like not the ideal setting for telling someone that they've got lung cancer. It's there's a whole raft of things that makes it worse. So I just want to come back to this idea of the staging and the impact that that has on the prognosis for someone who's diagnosed with lung cancer. So these are some figures that are different malignancies. And I just use breast cancer and lung cancer as the contrast. So if you look at breast cancer, can you see my arrow when I'm using it?
Yes, we can.
When you look at breast cancer over here, this is actually Australian data, that the vast majority of people are diagnosed at stage 1 and 2, so in a curative phase of their illness. And only a very small proportion of women are diagnosed with metastatic disease at primary diagnosis, as opposed to lung cancer, where 42% of this group of patients were diagnosed at stage 4. And that's probably an underestimate because there was actually 29% who never received a formal staging. So a good chunk of them would have been stage 4 as well. So you've kind of got this really common cancer that's usually diagnosed late, which means it's less likely to be curative, and previously treatments haven't been particularly effective.
They're an extremely bad combination of statistics, aren't they?
Yeah, and definitely, like if you look here at looking at just Māori men alone, so this is really to demonstrate how much of a burden lung cancer is even compared to other malignancies among Māori men. So this is looking at this standardized mortality rate. And it's estimated that around 160 Māori men die each year of lung cancer. And hopefully this has worked, Lucinda. I should have put them next to each other, but this is comparison to non-Māori. And so if I go back, the age standardized mortality was 26 per 100,000, as opposed to non-Māori, it's 8. So, this just plays out in my place of work. One more graph, and again, this is just looking at, this is males in New Zealand, and this is Māori versus non-Māori as far as the incident rate of diagnosis. So there's a really significant difference, again, between the proportion of the incidence of diagnosis. So I'll kind of shift the focus onto treatment and the types of treatment that are available now. So in the first treatment I'll look at is what's called targeted therapy. And I just want to emphasize again, this is for non-small cell lung cancers and in particular adenocarcinoma. And that you're only a small proportion of patients are eligible for this treatment. But for every single patient who's diagnosed with an adenocarcinoma, we now check for these mutations that allow the patient to be eligible for this targeted therapy. And they have really good outcomes, and it means that they don't need to be on chemotherapy. They can just have these targeted treatments. So it's really important to identify these patients. So basically, this is the presence of a gene mutation within those adenocarcinoma that then kind of turns the cell into overdrive. It proliferates and it goes unchecked by your normal systems that prevent cancer from getting away. So if those mutations can be identified, patients can then be put onto enzyme inhibitors for the long term. They'll stay on them, and these are tablet medications, and they usually end in the term nib. And they can be on this targeted treatment rather than being on chemotherapy. So we know that there's lots and lots of mutations that drive adenocarcinoma, lung cancer. But in New Zealand, we only currently check for EGFR and the ALK. And you might see that on the top of clinic letters, it'll say adenocarcinoma EGFR mutation present. And the reason we only check for those is because we've only got funded treatment for that EGFR and the ALK. And at the moment in New Zealand, we don't even have the first line. So we don't even have the best therapy available. So for the EGFR one, it's the funded one is erlotinib. And for the ALK, it's, I don't even know how to say that, alectinib.
And so, don't you just love these oncology drugs like that?
Yeah, I don't really care.
Medicine's got enough
because they're all made up
without these ones. And just so people know that the EGFR is not your estimated glomerular filtration rate.
No, okay, endothelial growth factor. Yeah. So the best therapy is actually osimertinib. That's got the best evidence for it. So a number of patients actually fund this themselves, but through I'm not sure if it's dodgy or not, but they pay a man in Auckland who brings it in from Sri Lanka, and that costs about $800 a month. Whereas if they self-funded through the proper channels, it would be $10,000 a month.
Wow. Ooh. Can anyone just access this guy in Sri Lanka? Like if you had a patient, is it relatively easy to find this person's number? I suspect it's sort of well known within the
number of hematology drugs and oncology drugs. And it all seems above board, and everything seems to work quite smoothly. But yeah, it does all feel slightly precarious, like things could fall over. Yeah. I guess from a rural hospital point of view, hospital doctor point of view, the things to be aware of with these drugs is they're really well tolerated. So they're tablet medications, and compared to being on chemotherapy, they're much more desirable, but they've definitely got side effects. And the main things people experience are diarrhea, and they get rash. And it becomes like any chronic disease, because first of all, this person had lung cancer they thought they were going to die from. Then we told them they've got a good treatment. So we start the treatment, but then they feel good, but then they get all these irritating side effects. And you actually end up having to do the same thing you would for a diabetic, like convince them to stay on their treatment. So I think the main things with these drugs is an awareness that if it ends in IB, it might be a cancer drug, and that there are really common side effects associated with them.
Is that rash manageable, or does it stay looking quite, do you get milder forms in that, or is it quite significantly disfiguring?
Like most of the patients who I've seen have got a reasonably mild form, and largely it hasn't been involving I've got one woman at the moment with on her face, but mostly it's been their backs. And if you use like a low-dose steroid cream and emollient and things, it's manageable. There's actually a correlation between the effectiveness of the drug for the cancer and the likelihood of them developing a rash. So that's one of the things we use as a selling point. We're like, this means that, the cellular process is actually happening well at the cancer level.
It's like you tell patients were taking their TB drugs in India because the colour of them.
Yeah.
you could tell if they were doing.
I won't dwell too much on this, but like the outcomes are just quite incredible. So at the top yellow bars are, for instance, we'll just take non-squamous with the chemotherapy. You're looking at a median survival of sort of 12 or 14 months. And those patients with the ALK mutation, if they're on alectinib, the studies so far, like the median survival hasn't even been reached. So these people have years and years ahead of them, and they actually, apart from the side effects of the drugs, they can live really normal lives and feel really well, whereas this used to be a death sentence, when you're measuring life within months. And then even so the Aussian version of the one that they get through the drug dealer in Auckland, median survival is 39 months. So again, you're looking 3 years onwards, and some people will do much better than that.
As you say, a glimmer of hope.
A glimmer of hope. And I think the other thing for that, for all doctors, is just having an awareness that these people have a really different prognosis when it comes to treating their other comorbidities. So that means a big difference. Like if patients are rocking up and they are wanting joint replacements, or they're really unwell from another intercurrent illness, they make an appropriate ICU candidate versus previously probably not so. And that's what I'm noticing with these patients, like they're getting their other chronic conditions are actually starting to come to the fore. I think I've said all those things really. So this is a chap who, I haven't actually seen this guy, but my boss has had a lot of said, this is a real success story. It's a 67-year-old chap. He'd only smoked a little in the past. So that's just one of the things that often non-smokers have these mutations rather than smokers. He presented in June 2020 with extensive disease, and we don't need to go through his entire report, but the point is he had disease everywhere, like right through his skeletal system, all through his organs. But fortunately, if you're going to have some good news in your lung cancer, it's finding a mutation. So fortunately, he had the ALK mutation, and he was started on alectinib, which is one of the funded ones in New Zealand. And he was told, to expect durable response for kind of 3 years onwards. And he works in forestry, and he's still working full time, doing really physical work. His PET CT in December showed like a full metabolic response, which means that his cancer's basically just like melted away, and his CT just remains stable. So this is comparison CT here. This is actually not just tumor, that's some collapsed lung as well, but a big chunk of that is his primary malignancy, and then this is on his most recent scan, and it's remained at that size for quite some time.
Matilda,
yeah,
just 2 seconds. Gary, do you just want to ask some of those? There's just one question there.
Yeah, there's probably a couple that are sort of related, but it does go back right to the beginning, Matilda, around diagnosis and about delays particularly from primary care in terms of getting imaging.
Yeah.
I don't know if that's something you can cover, but the other one, which is again a classic one, and that's around following up a patient who's got an area of consolidation and just checking down the track to see whether or not that's fully cleared. But I mean, the classic being the 6-week chest X-ray.
Yeah, I think I'll say that one first. So I think Lucinda, I just realized my things weren't actually working, so I'll just take you on. So I think that's kind of been traditional dogma to get that 6-week follow-up chest X-ray, and I guess that's never really been tested in randomized controlled trials. And I think the main thing I'd say is kind of you have to use your clinical judgment. Like if you have got a high-risk patient who's a smoker, who you've got a concerning appearing chest X-ray, this is their second or third infection, and it appears that they've got some collapse, so there could be something quite structural in there. I think it's really important to get that 6-week follow-up X-ray. And then I guess it's making sure you know who's going to actually chase that, because I don't know, within our hospital, and even when I was working down in Taupo, we had a few where, yes, that was arranged, but then it was unclear who was actually going to be the responsible person for following that up. So I guess, that closed loop of who's going to check. Would that kind of answer that question, Gary?
Yeah, it does. What about the situation where the person presents with in the area of infection, but there's a few features there that actually make you suspicious right up that there's likely could potentially be an underlying malignancy.
Yeah.
Do you know how well a CT right at that early stage differentiates between infection and malignancy?
So first of all, I think the first part of the question is that those patients really need a CT, because if you've got clinical suspicion, then they should have a CT. And in a world where resources weren't an issue, you would do a CT at that stage. And if that wasn't clear what was just consolidation and what was tumor, then you'd get a follow-up CT later down the track. And I think that's kind of what should be happening. Usually you can differentiate the tumor from malignancy. And if there's other ongoing concern, then the kind of next step is to do something fancier like PET scan to try and differentiate. But again, infection can kind of confound that interpretation as well. But I think if you're thinking from a rural point of view, really, and if you haven't got access to CT, I think we're really advocating for your patient, like their risk profile. So if it's, a Māori patient, if they've been a smoker, then they really should be getting CT scan as their imaging of choice, because so many of these will go missed on an X-ray.
Just coming back to that follow-up chest X-ray, obviously I work in primary care, and it probably does differ depending on where you work. But if I get a discharge summary back saying da-da-da and we need a repeat chest X-ray, I will put a recall on the system and I will organise the chest X-ray, and then that's my responsibility. I feel at 6 weeks out that's really moved to primary care versus being a follow-up from the hospital system, because I think then but that comes down to good communication and understanding, and I think that's the standard of care within the Tairāwhiti region, that's how we would do that, because otherwise I think it does lead a degree of, if the hospital clinician organises a chest X-ray repeat in 6 weeks, that is the clinician who orders the test's responsibility. But if they're expecting someone else to follow that up, so I think those discussions are key to be had, aren't they? If there's
and I really try and get that across to
clear.
the junior doctors to make that really clear on discharge summaries, what the expectation is and who's going to follow it up. And I guess that when you're the rural hospital receiving people back from a tertiary hospital, that's a point where mistakes can happen for sure, if there hasn't been clarity around who's actually going to order it and follow it up.
And I would say that if CT access is a stumbling block, which I would imagine it is for most people, that then comes the do the follow-up chest X-ray, and then if you have ongoing clinical concerns or your clinical gestalt says to you, I'm still remain concerned, and also being an advocate for these patients, because if this is one thing I've learned from this, is in being a massive advocate for those high-risk populations, particularly obviously our Māori and our rural, and maybe they don't even need to be smokers obviously now, but we just need to be advocate for them, because at the moment with the way our health system is and accessing these images, if we're seeing the patient and we're worried about them, we should be pushing, shouldn't we, to get the radiologists can't see them. So it's about us being able to communicate to them, these are my concerns and this is why I want this, and then pushing for it, I think is probably key.
Yeah, and I think that, that's good patient care, but now that's coupled with treatment that people can access that's actually going to make a difference for them. So I think there's even more justification for it. Shall I move on to
there's a bit of chat there about the relative role of the radiologists and the GP or the respiratory physician. But I guess it's possibly helpful when you're writing that request for the follow-up chest X-ray to make it clear that you're wanting to rule out a malignancy, because then almost invariably the radiologist could say that they can't do that, and therefore perhaps make recommendations for a CT. Would that be a helpful approach to getting the test done?
Yeah, I think so, because as soon as someone puts in those CT requests that have higher suspicion of cancer on them, then they do get bumped up the priority list. And I think I live in even though we don't have many radiologists in our area, we do I know that imaging is much more timely than other places. So, I'm really aware that I can say these things, but other people will be finding it really challenging. It's the radio. Should have decided. So if I change tack onto immunotherapy. Sorry. or the other term that's used here is checkpoint inhibitors. And this is really cool science, and it's just a growing area in oncology and in other the treatment of other like autoimmune conditions and things. So I think it's important for everyone to sort of have some understanding of how this treatment works, and in particular the toxicities associated with it. Sorry, I flipped past the slide. So I'm just going to come to the mechanism of action of the immunotherapy in cancer. So I like to think of tumor cells having kind of a disguise, so the immune system can't detect them and clear them. And this disguise is, one of them is PD-L1. So the tumor cells express this PD-L1. The PD-L1 interacts with the T cell, and that kind of quietens the T cell down, and it doesn't recognize that this is a tumor cell that it's seeing. So it doesn't really have any action to take against the tumor cell. With the checkpoint inhibitors or immunotherapy, so now we're talking pembrolizumab or Keytruda, these interact, they're monoclonal antibodies, and they bind to these receptors, either the PD-L1 on the tumor or the PD-1 on the T cell. And that means that interaction is no longer happening. So now the T cell is able to see the tumor cell for what it really is, and it's able to carry out its action of clearing and killing that tumor cell. So I like, when I'm explaining this to patients, I kind of say that this immunotherapy is enhancing your immune system's ability to do its job by taking the disguise off the tumor cells. And I'll come back to this image as we go along. So just a little bit of the history, like the idea of infection and immunity in cancer, you know, goes a long way back in history. And there's kind of documentation of, and even like in the ancient ancient Egypt, of people deliberately using infection into tumors to kind of trigger an immune response. And there's a story that this is Saint Peregrine, who's the patron saint of cancer patients, that he had a fulminant infection. He had a tumor, and he had a fulminant infection in proximity to that, and he apparently had complete resolution of the tumor that he had. And the third picture there here is he was a surgical doctor in America who dealt predominantly with oncology patients, called Dr. Coley. And he was really tired of seeing such dismal results for his patients. And he read some case studies of patients who had had localized infection and had regression in their tumor. And he started to do his own kind of types of studies by inoculating people with strep throat and that type of thing to see what type of response he would get. It's really hard to know, because obviously this is like not the rigors of, you know, modern day science, but, you know, apparently he did have some pretty good results, but was typically ridiculed by his colleagues, which is, I think, often the case when people were having kind of new ideas in medicine. And if we skip forward to the 1980s, was the introduction of interleukin treatment. So this woman is a patient with metastatic melanoma, and she was treated with interleukin and had full and complete resolution of her malignancy. And she's still alive today. So that's not actually her images, but a patient from that kind of cohort. And so interleukin was kind of, you know, people really pinned their hopes on this, but unfortunately sorry, that's just a graph of responders. So if you had a complete response to the interleukin, that was like there was definitely cure. So people had a complete response and sustained response, whereas the survival really dropped off for those who were only partial responders to the treatment. Unfortunately, there were lots of toxicity associated with interleukin, and there was quite a few deaths, and it was not really deemed, you know, safe that it could be rolled out as a sort of general treatment for metastatic cancers. Then fast forward to the development of immunotherapy. So these are two scientists, that's James Allison and Tezuka Honjoy, who were joint recipients of the Nobel Peace Prize for their work in the area of immunotherapy. And so this was kind of in the like the late 1990s, early 2000s was when the progress really started to happen. And that's when pembrolizumab really came to fruition and was started in the treatment of metastatic melanoma. Was the first cancer it was licensed for, and the first it was available for in New Zealand. So it's been funded in New Zealand for a number of years now for melanoma. And just to remind you again, so this is pembrolizumab or Keytruda interacts with the PD-L1 monoclonal antibody, interrupting that interaction. So this is just a sort of timeline of what happened in America as far as the trials go. And I don't want to go into them in lots of detail, but basically the indications grew and grew really rapidly. So there wasn't much hope for lung cancer, actually, when they first started doing these trials, because it wasn't thought that cancer was a particularly immunogenic malignancy compared to melanoma. So it was actually quite surprising that these cancers showed such a good response to the pembrolizumab. And then as things evolved, that quickly became licensed. But if you look at New Zealand, we kind of took way off the end of here. So despite, pembrolizumab being pretty standard of care overseas, it wasn't until this year that it became funded treatment in New Zealand. I just want to say one thing just about, I'm just going to go back to this one here. You will see in clinic letters as well, they actually report the PD-L1 count. So when you get your tumour looked at, they give a percentage rating of how much PD-L1 there is, 0% through to 100%. And the higher your PD-L1 score, the more likely you are to respond to Keytruda or pembrolizumab. So that's something you'll see. That's always at the top of the letters. I'm not going to dwell too much on the studies, but I just will, just 3 of them. I thought when I found a keynote study when I first started as an oncology reg, I talked to my boss about it, and he's like, well, there's 680 keynote studies because they just pump out these trials all the time. But this one was a really key one because this looked at pembrolizumab versus chemotherapy in patients who had that PD-L1 expressed greater than 50%. And the median survival was 26 months versus 14 months. And that, in oncology study-wise, that's really significant. That's a really meaningful difference in outcome. Plus, the pembrolizumab is so well tolerated. So you're pretty much giving these people this drug that doesn't really have any particular side effects for most patients versus chemotherapy, which is, nasty. And these are the typical graphs of oncology studies, and that's a pretty convincing breakaway there in the Kaplan-Meier curve. The next study was wow, if it works in these patients who have really high PD-L1 counts, will it work in those who have low PD-L1 counts? And in a nutshell, the answer is yes. So the response wasn't quite as strong, but even if you had a PD-L1 count of 2%, you still had a pretty good response to pembrolizumab or Keytruda. So this is those who have a higher PD-L1 count down to these who have a lower PD-L1 count. So the difference isn't quite as dramatic compared to chemo. And then I won't dwell on that one. And then the next question is, can you give chemo and pembrolizumab versus chemo alone? Is that safe? And that, in fact, has been shown to be effective as well. And that's the mainstay of treatment now in New Zealand. Unless if your PD-L1 count's greater than 50%, you actually just get pembrolizumab. So you don't even need to be faced with having chemotherapy. But if you're in those lower numbers, you have pembrolizumab and chemotherapy. Does that kind of make sense, Lucinda?
Yes, thank you.
And these differences are sustained out to 5 years. So these trials are a little bit confusing because the 5-year survival in that trial is 20%. And you might ask, why is it so high if I told you that everyone dies of stage 4 lung cancer in the control arm? But there's heaps of crossover with these studies. So patients who are in the control arm, because of the success that came to bear, lots of those patients will eventually get pembrolizumab down the track. So what's happened in New Zealand? So in the last, since March, pembrolizumab has been funded for lung cancer, and that's made a huge difference in our community. So I used to sit in clinic last year with our lung cancer patients and have these awkward conversations about do you have any money, do you happen to have any money, do you happen to have $10,000 a month that you're not quite sure what to do with, and lots of our patients can barely afford to pay their power bill, but we never wanted to presume that they didn't have access to some money some way. So this has been a real game changer as far as access goes. And the other drug, atezolizumab, that's just the second line treatment for people who've had progression, not to worry too much. It makes a really big difference for patients. So I think if you're in the rural setting or working in general practice and you're faced with older people or more frail people who are diagnosed with lung cancer, it kind of makes it more worthwhile to refer them to oncology if they want to, because you can actually just give them immunotherapy rather than chemo. So lots of patients who wouldn't be a candidate for chemotherapy, we will use immunotherapy because it's so well tolerated. And it's generally given every 3 weeks. So, it is going to be travel for people. So that does need to be, taken into account. I have a question for Gary. I couldn't remember, in Dunstan, do your patients get this administered there, or do they have to go to Dunedin for their chemo and if they had immunotherapy?
It's pretty frequently it's done in Central.
Yeah.
They don't have to go to town.
Yeah.
Often for the first dose of something, they will have it in Dunedin, but for subsequent doses, they'll have it done locally.
Yeah. And that's the case in Taupo. So our patients will get their first dosing done up here, but then they can get all of this in Taupo, and we do clinic down in Taupo as well. So I've mentioned that it's really well tolerated, and for the most part it is. Like, patients tell me they barely feel that they've actually had it on the day and on the days afterwards. But there are toxicities, and they're somewhat idiosyncratic, and they're unpredictable when they're going to happen. And they're basically autoimmune toxicities. So because of the way the mechanism of action of the pembrolizumab, it can trigger autoimmune illness in any organ system in the person. So the really common ones we see are thyroid. So we see heaps of hypo or hyperthyroidism, but that's pretty treatable. It can cause rashes. And then the more serious things is it can cause a pneumonitis and a colitis. And I think that's one of my take-home messages, is that I'd be really wary of your patients who are on these drugs, and you will see more and more of them who come in either with progressive breathlessness or colitis, and because it needs to be treated in really quite a different way. And we've had a few patients who it kind of hasn't been thought of, like everyone's been thinking, oh, it's the chemo, or it's infection, or it's disease progression, when in fact it's the pembrolizumab itself. The way it's managed, it needs to be obviously discussed with the oncology team, but there's really clear protocols around how to deal with it, and a lot of that is stopping the medication and steroids. And often people can go back onto the medication, for instance, with hyper or hypothyroidism. That's pretty easily sorted out. I think that's going to become more and more common as these drugs get used more and more. And I've seen we've had one patient die this year from hepatotoxicity. So there are serious complications. Just for a point of clarification, which kind of I'm sure most of you get, but often when we see these patients in ED who are just on immunotherapy, they've been treated like other cancer patients, and they're in a side room, they've had a temperature, someone's given them Tazocin, but they're not actually neutropenic. Like, this is not an immune suppressant drug like chemotherapy is. So they're immunosuppressed because they've got cancer, but they're not immunosuppressed from the treatment itself. And that's just the management guidelines. So if you ever had anyone who you're wondering about, you can just look up the international kind of guidelines on how it can be managed. Do you have any questions at that point, Lucinda? I feel like I've talked heaps.
No, but I feel like that's going to be a lengthy document.
Yeah, but easy. It's pretty
easy to follow.
Easy to follow. Yeah.
No questions, Gary. I haven't.
No, but Matilda, I mean, that's a very, very important point, isn't it? That is very easy for us to, because we get very used to treating or seeing patients who are on chemotherapy, and we know what to look for, particularly in terms of neutropenia and the common side effects, which are likely to settle over a bit of time.
Yeah.
But this is a completely different ball game, isn't it? These particular, and we have to have quite a different approach and quite a different threshold for discussion with the oncologists and for transferring the patient to town. That'd be right?
Definitely. And I think like some of these patients, they'll just be able to guide you over the phone, the use of steroids and that kind of thing. But I think I've just noticed from discharge summaries, and particularly with junior doctors, because this is also new, like often they'll say, this patient is receiving chemotherapy. I think they've got diarrhea because of the chemotherapy, and they're not actually on chemotherapy, but I think it's just the getting familiar with these drugs and them being, behaving in a really different way.
And Matilda, you've highlighted colitis and pneumonitis, but it's almost, the impression I have is that they almost can do anything.
They can affect any organ system, so you have to be really suspicious of any, it can affect the adrenal glands, and so you kind of like have a broad clinical suspicion with patients on this treatment who present with something odd that it could be due to their immunotherapy. I think that would be my.
And it's correct to say that it's not just a simple matter of stopping the immunotherapy, that once the immune system is turned on in this way, it often can be quite hard to turn it off.
That's right. And that can be like that woman with the hepatotoxicity. That was seemed the case with her. She was on really high dose steroid, but the process had been triggered and it was kind of rampant. Yeah. Gary, I'll just say one other thing, and with the effectiveness of Keytruda or pembrolizumab, is that the effect is actually diminished by steroid treatment and by antibiotics administration. So it is a setting, if you've got someone who is on these treatments, we should be judicious anyway, but just really thoughtful about giving antibiotics and putting people onto steroid treatment. So say if, a patient's got a lower respiratory tract infection, that kind of thing, it's probably a situation where I've been more inclined to discuss it with the oncologist than other situations, because of that sort of suppressant effect on the immunotherapy from antibiotics and steroids. Did you have any other questions, Gary?
No, I think I certainly found that very helpful, Matilda, and hopefully others did. But it is, we definitely have to start thinking about these patients in quite a different way to what we've tended to think about our traditional chemotherapy patients.
I just saw Alex asked a question. He said, do all cases go through the MDM process, and how long is the process from imaging to biopsy to MDM to start treating? And Alex, so yeah, all these cases go through the MDM. And I can only speak for my region, but I think that's standard approach across the country. So that'll be for lung, that's respiratory oncology, the radiation oncologists, pathologists. And yeah, I'm really lucky. Like in Rotorua, we seem to have a really good match between the resource of oncology and the community need. So our patients get started on treatment, they get seen really fast and they get started on treatment really fast. But I know that's not the case across the country. I know, like, for instance, for those who are in Otago or Canterbury, I think there's much more of a hold up for initiation of treatment. The good thing about patients who are getting pembrolizumab is it's like an hour, they come in, they get their treatment, they go, as opposed to some other chemotherapy that can take much, longer to administer. Can
you see that, Matilda? And thoughts on doing biopsies at rural hospitals?
Oh,
be pretty tough, wouldn't it?
So, yeah, they need to be, of lungs. They need to be
You're
like
keen, Alex.
Yeah. Crikey. Well, the thing is, you can get pleural fluid, but pleural fluid, what you get from pleural fluid is not particularly good for the full histology, and it's not, it's not always going to show anything, but sometimes it shows nothing. And if you're going to be looking at lymph nodes and that kind of thing, you do need to do a core biopsy rather than an FNA. So it is kind of difficult. But Alex, you can do anything. You can upskill into anything. But yeah, it is a bit of a stumbling block, the biopsy, I think.
Okay.
And I think the other thing, just to be, what happens, I've worked out with oncology, is that they try these drugs in the palliative setting, and if they're effective in the palliative setting, so non-curable, then they start using it in the, like we say, neoadjuvant, before surgery, adjuvant after surgery. So now this is being used, these are being used for stage 2 and 3 cancers that are curative as well. Like that's what happens overseas, but we don't have access to that in New Zealand. But yeah, so there's like, apparently there's about 12 indications for pembrolizumab that are in standard of care overseas that we wouldn't be able to access.
Bring on the next 10 years, though.
Yeah. But yeah, people living longer with all the other issues becoming more pressing.
I'd keep rolling, Matilda. Keep going.
I'm finished, actually, I think. I was just having a look at the questions, sorry. That was my thing there. Oh, I'll do my last case. This was this is amazing. This is a man I saw when I first started in oncology. He's a father of 2, and I think it was if his kids were the same age as mine. And so that was, I think, has more of an effect on you emotionally. He's he said he'd had a really interesting past, but then he'd fallen in love with his wife and changed all his ways. He'd been in the same job for years and years, and he presented with rib pain. He'd had treated Hep C in the past. He'd smoked a lot historically, but he'd stopped a number of years, and he had very well controlled depression. So he had a cancer demonstrated on chest X-ray, a very low PD-L1 count. So that was that count I was talking about before. This was pre-funding in New Zealand, so he paid for his chemo. He self-funded the pembrolizumab they remortgaged their house. And he had some radiotherapy because he had a lot of pain. And he had a really excellent response. And he's 18 months down the track now. He works full-time. He looks, you'd never, ever think he had lung cancer if you walked past him, in the street. And that's the change in his chest X-ray, his CT, on the coronal section. And it's continued to stay with that appearance. And that's the other thing I just reminded me, like, I think since I've done oncology, I've got more of appreciation for the effectiveness of radiation oncology. And, that's another real stumbling block as far as access. But I think, trying to, again, advocate for your patients to be seen by radonc if they've got bony metastases, your prostate cancer patients and your lung cancer patients, that it can be a real game changer. And I think that's my final slide there.
Matilda, if you've got a few spare minutes, obviously something that we deal with pretty frequently in rural hospitals is malignant effusions.
Yeah.
Or undifferentiated effusions that are likely to be malignant. Have you got any tips around the management of those?
I think that I'd say that the really useful thing, because so many, I feel like draining them so that diagnostics can get rolling, if that's going to be helpful. The other thing I'd say is that I think I hadn't really grasped before how effective treatment like chemotherapy can be for actually getting control of effusions. So that's that thing of trying to get people to be seen and to be managed, so they don't keep needing to have their effusion drained. Like, this is early on in their malignancy, before they've got disease that's not responsive to chemotherapy. I think once people get to the point that they're getting recurrent effusion, like, what I'd say is, if people could, like, people who are happy putting drains in, I reckon it would be great if more people could upskill to do tunnel drains, because I think that that's what's happening. Respiratory physicians are doing that, but I think lots of rural hospital doctors would be quite capable of putting tunneled permanent drains in that district nurses can then go, can drain. Because I think that I'd say that a lot of rural patients miss out on tunnel drains because of difficult access.
What about the decision around a tunnel drain versus pleurodesis?
Yeah, I guess I'm like, because of working here, we've got relatively good access to tunnel drains. And I think that, because I think you guys are pretty comfortable doing pleurodesis in Dunstan. So I think that that's like a really, if someone's going to not be able to get a tunnel drain and they're coming in and out of hospital to get their drains done, then I think pleurodesis is a really good option if people are comfortable with, you know, doing that procedure and the patient's prepared. Yeah. The other thing I'd say is that lately I've just been like being cautious of, or just having in the mind the possibility of pericardial effusion as well. We've had a few oncology patients recently, young women actually, who presented just really, really unwell, just non-specifically unwell. And they've actually had tamponade, and I just realized that, I don't know if I've previously kind of had that on my, really high on my thinking, you know, and that's something that, you know, lots of rural doctors are really comfortable with using echo, ultrasound at the bedside, looking for pericardial effusion as one of the, you know, oncological complications or emergencies that can really tip people off their perch.
Has anyone else got any other oncology orientated questions related to lungs? Only lungs, because you'll see that Matilda's going to come back next year and cover oncological emergencies. So you have to hold on to those questions till next year. Okay. So anything else on lungs specifically? Come on, team. Right. I like your questions, Gary. Keep going. It's like listening to two brains work. It's beautiful.
I will keep going then. Total, what about during that initial drainage when there is not a diagnosis? Have you got what's your schema for how much fluid you take, how you, what's your regime for taking it, what sort of samples you send away, what sort of blood samples you send away at the same time?
Yeah, I think that I use the Unico drains, like the ones with the wee safety tip. I don't actually do that often. I don't do the Saldinger technique at initial drainage. I usually drain until as much off as you can possibly get from a therapeutic point of view, up to sort of 1.5 litres, or I stop if the patient's getting uncomfortable or coughing, or any of their obs are looking like they're going in the wrong direction. So I think, you know, there's that theoretical risk of re-expansion pulmonary edema. So it's important to have the patient, you know, monitored quite closely. And I think that sometimes if you take off, say, 500 mils and they start to feel a bit uncomfy and cough, you can clamp and then reopen it and see how, you know, once things have settled, to get some more volume off. I remember talking to the laboratory. I thought that the laboratory was like, the more volume, the better. So I used to send off heaps of it. I used to send off big bags of volume, but I don't think they need quite so much as that. But, you know, as a few 100 mils is going to be useful for them. I think asking for a cell count and your glucose, your protein count, you know, all your sort of classic things that mean you can differentiate between transudate and exudate, and then asking for cytology and you know, so that you can see if there's any evidence of malignancy on there, and then a culture and sensitivity, of course. The one time the Unico hasn't worked for me was a patient who had mesothelioma, and I think the fluid itself was so thick and almost like honey that until we put a bigger drain in with a Saldinger technique, we didn't get any volume off. But I think that, you know, if you're going to be doing if someone's symptomatic and you want some of that fluid off, I think getting a decent volume off rather than just doing a small sort of diagnostic tap is, you know, it's probably better to do a sort of a therapeutic tap at the same time. And I think just that importance of repeating the chest x-ray afterwards. Like I feel like, you know, it's not uncommon for people to have small pneumothorax afterwards, but, you know, you just want to have that sort of documented and not feel terrible if that occurs.
Matilda, if the fluid's coming away pretty freely and it's a large effusion, do you have, even if the patient is quite comfortable, do you have a point at which you will stop after a certain amount is drained and then give it a rest and then carry on, or do you not worry about that?
I usually stop at like 1.5 litres. But if the person, and then often they will tell you if they feel better with that anyway. Yeah, and that seems like the respiratory physicians, that's about what they take off. Sometimes if they've drained that person a few times, they might be more comfortable to take off maybe like 2 litres. For sure.
And then would you stop for an hour and then take more?
Yeah. Yeah, and especially if the person's with you and it's no problem for them just to sit around, then just letting the lung re-expand, and then you can get some more volume off a bit later on while you've got the drain in place, for sure. I think just being other safety things, like if the theoretical risk, like we'd say, I always just make sure people check the platelets and check the coag screen, and just being aware that if patients are anticoagulated or on antiplatelets, then you really want a window that they haven't had their medication before you go sticking your needle in. And if they're on warfarin, you need to make sure their INRs, I think, down less than like 1.2 to do that safely.
This question, Matilda's going back a wee bit, but we haven't really talked about, like, obviously all of our people work in rural settings. We haven't really talked about when we should refer into our more centralised centres. Like within these patients, obviously we're going to discuss them, but have you got some guidelines around when we should definitely discuss these patients? So
I think that, like Alex was asking, most of these patients will go through the MDM process.
But once they're diagnosed and once they're on the treatment, so this is more for the acutely unwell, or...
Okay, so I'd say that what I was going to say for that is that it's normally the respiratory physician that's going to facilitate them getting through the process of all their diagnostic workup. So I think getting the respiratory physicians involved early, and they're such bread and butter for them dealing with lung cancer, that they're going to be your point of call as far as, say, if you're not that familiar with the pathway in your area, they're going to be the person to talk to guide you through how this patient's going to be worked up. And they do, they facilitate a lot of the breaking of the bad news and that type of thing. So I think, and the other thing, locally here, our oncology nurses are really useful, particularly if it's looking very much like it's going to be a malignancy. So for instance, our patients, say from Murupara, the GP there will just contact our nurses directly early on, so that they've kind of got that connection even before they've had a formal diagnosis and plan. Yeah, so I think the respiratory team are they facilitate all the workup of these patients, of these lung cancer patients. So they don't actually come directly to oncology until they've got an absolute diagnosis with tissue diagnosis, basically. That's one of the odd things about oncology, is there's not an awful lot of diagnostic workup. Like, people kind of cut by the time they get to oncology clinic, they've kind of got all that information there with them. Yeah.
And with all the side effects of the drugs and things, you just call your oncologist and organise a plan.
Yeah, and again, the oncology nurses can be really useful. So there's there's usually oncology nurse specialists. So I think in your area, as you were telling me the other night, you don't even have an oncologist on site in the Gisborne area.
No.
So the CNS there will be a real wealth of knowledge around side effects. And also the chemo nurses can be really good as well, because they see the patterns, and they talk to the patients all the time about the side effects from the meds. Yeah. Okay, and great. There's a really, really useful, it's like dense, but there's a thing called EVQ, which is an Australian website which looks at all the different chemotherapy regimes, but also side effects. So you can go to common side effects. So say someone comes to you with lots of oral ulcers, or diarrhea that's just chemo related, or nausea. It gives you guidelines as to how to deal with those side effects. And I think I've used that, like recommended that to some of the like total ED doctors, for instance, have had patients come in there, and I've been like, just go to this and see what they say, and it's like practical guideline. I'll just
good. We can send that out in an email afterwards too, couldn't we?
Yeah, it's one of those awesome resources that we couldn't probably afford to create here, but it's good that we can use Australia.
Brilliant. Okay. There's just one more question there, Matilda, which we might end with this one from Graham. Have you got any comments on that? PCP?
Oh, that's a really good question, Graham. So PCP, pneumocystis pneumonia, which is we largely only see in immunosuppressed patients. So on immunotherapy, patients shouldn't be at any higher risk of getting PCP pneumonia. If you've got patients on chemotherapy, and especially like hard chemotherapy regimes where they're getting more toxic chemotherapy. So the example is breast cancer patients. They get that, it's called AC chemotherapy. That's the awful stuff. People feel terrible. They're definitely at risk of getting PCP, and I've seen it in a couple of women. So I think the point for a generalist doctor would be, if you've got patients who are on chemotherapy, presenting with pneumonia, not responding to initial treatment as you'd think, then raising the flag of the possibility of an atypical pneumonia like pneumocystis is, really important. And you may be the only person to think of it. Like, I've seen these patients in a tertiary hospital getting treated for standard pneumonia, and no one's thought, could it be pneumocystis, until someone kind of has that moment. With regard to bronchoscopy, really that is the main way of getting a firm diagnosis of PCP pneumonia, unless the person's bringing up really good amounts of sputum that can go to the lab. Yeah, and that needs quite different treatment.
I wondered if you had some experience with that, Graham. Thank you very, very much, Matilda and Gary. It's been a fabulous evening. I have thoroughly enjoyed that and learnt a heap. I've obviously been out of rural hospital a wee bit, so I had to look up tunnel drains. So the power of Google, eh? So thank you very, very much, Matilda. If everyone could please fill out the evaluation form, we really, really appreciate that. And that is part of us providing this ongoing CME. And yes, I will look forward to inviting Matilda back next year, and we're going to have a look at oncological emergencies and exploring those. So thank you very much, everyone. And we'll catch up with you in December, when we are going to have a general surgical talk looking at abdominal presentations then. Okay, thank you.
Thanks, Lucinda.